For me, heterogeneity reflects that different patients respond to different treatments in different ways. We're not all the same, so it's not a one-size-fits-all kind of a situation. Heterogeneity is already being incorporated by payers in a lot of different ways. For example, if we know that because of your gene type with hepatitis C that you need 24 weeks of therapy versus 48 weeks of therapy, payers will reimburse according to that heterogeneous fact. Also, payers put in step therapy edits where maybe you need to have a test and find out if that drug is right for you or wrong for you, and then you can move on. So there are a lot of ways in which payers are today incorporating heterogeneity. Payers could use both CER and heterogeneity at the same time. For example, you may find overall that a drug like Procrit is very appropriate for some patients, but then the payer may want to pay for monitoring of blood tests to see, when the hemoglobin gets above 12 for that individual, it's time to stop. So you can have a kind of a CER global coverage policy, and then you can tweak it at the individual level. One of the key areas I think that's very important in the next few years in this area of heterogeneity is doing studies around clinical utility. That is, if you do pay attention to it or you don't pay attention to it, does it make a difference in terms of patient outcomes? There's been a lot of great science around picking out the subpopulations that do and don't respond, or the safety issues. But trying to figure out, does it matter? Does it matter if you look at those questions? Can you really make a difference in the population health? That's the kind of studies that payers and others are looking for, and there aren't a lot of them. So I think that's an important topic for the future.